So we go from fantascience to much simpler science, which is a case of Wolf Parkinson wide ablation that we just performed a few days ago. I thought it was interesting. We had very nice tracings and something which was quite weird and misleading during the procedure, but eventually we got it right and it was good for the patient, and you will see what I'm talking about. So this is a 35 years old female patient, and she had recurrent SVTs with evidence of WPW on 12-lead ECG. She underwent an ablation in different centers a couple of years ago. The ablation was abolished the pathway conduction during the procedure, but eventually the pathway reappeared the day after the procedure. She was taken back for a second EP study, but the pathway was not there, meaning that it was damaged, but unfortunately not damaged enough. And in the ECGs that she showed afterwards, there were clearly intermittent pre-excitation, and she was going on, she's been going on for a few years with the history of recurrent palpitations and dizziness. Actually, when I talked to the patient, I was not really convinced that her symptoms were related to SVTs, but anyway, the ECG showed the pre-excitation pattern, and we offered the patient to undergo a new procedure and trying to chase and ablate the pathway. The ECG, as I said, shows normal sinus rhythm with intermittent pre-excitation. She had a stress test done elsewhere, which showed immediate abolition of the axillary pathway conduction during exercise, and she had a normal TTE. So she came to us and we performed the ablation. This is the 12 ECG at baseline, so you can really appreciate that there is no signs of pre-excitations at all. And eventually we look also for a possibility of conduction with VA conduction with the pathway, maybe damaged anterogradially, but still conducting retrogradially. But you can see here that we had concentric decremental conduction, meaning that we were going at baseline backward from the ventricle through the normal conduction system. But when we started isoprel, the patient went into a full pre-excited ECG pattern, so you can see the pre-excitation on the ECG, and which suggests pretty much that we are dealing with a left lateral accessory pathway, which is quite anterior. Delta waves in 2-3 AVFs, meaning that the pathway is probably anterior lateral on the mitral annulus. We look at the conduction properties of the accessory pathway on isoprel, and you can see here that we were able to conduct 1-to-1 at 220 milliseconds, and 200 milliseconds they were blocked on the accessory pathway, but still, again, a pathway that on isoprel, which doesn't, I don't know what that really means in the real life, but it was pretty nasty. So we try to induce SVT, so we can see here that we are pacing from the ventricle, and we induce an SVT, a regular SVT, which looks like an orthodromic reciprocating tachycardia. And we look at the VA of the tachy, which is 99 milliseconds. And so at this point, even though we had pre-excited QRS, and we still had to make a differential diagnosis with possibility of an atypical AVNRT. You see that the earliest electrogram on the A is on the East A, so which would fit also with a typical AVNRT. This is the position of the catheter at this point, so you see the CS, which is not really deep into the CS. And to confirm or to exclude the possibility of a typical VNRT, we did a Zeiss maneuver, and you can see here that on asynchronous pacing we were able to advance the A of the next beat, and in another occasion we have a delayed A, which actually confirmed that we were dealing with AVRT and not a typical AVRT. So we were pretty sure that we had to chase this pathway, but the question was, where the pathway is. And if we look back at this point during the AVRT, still with the CS catheter, which is not very deep into the CS, we were quite surprised, and we thought that this might be maybe a septal pathway. If there's anyone here that has different thoughts, and it was quite surprising and quite not going well with the pre-excited pattern of the QRS in sinus wave, which is consistent with the left lateral pathway. So what we did, and which always should be done, is trying to get bracketing of the atrial activity on CS, and that's what we get. So we had a much deeper CS catheter into the coronary sinus. Still we are in AVRT, and these are the signals. Is there anyone here that has a thought about where to ablate and what to do? Come on, don't worry. Sorry?
Did you map the mitral artery?
Yeah, we had a very deep CS into the mitral, into the CS catheter is going all around, and is quite anterior actually in the coronary sinus. So what do you think, what is the activation suggest here? What do you think that, where you would ablate? Still go for posterior septal area, going elsewhere?
Would you try to map on the left side the anterolateral area of the...
We don't have the ablation catheter is not shown here. You just have the...
But later on during the case.
Yeah, I will show you.
Or the left...
Just based on this, is there anyone has a thought regarding where you would map? In which area of the mitral annulus where you would map? Anteroseptal.
CS12.
CS12.
There might be an A on the CS12, and you might have a block because of the previous ablation.
Very good. That's what we, actually at this point, before we ablate, we had a pizza. And when we came back from the pizza, we saw the A that you saw now, even without the pizza. And actually, this is the position of the CS catheter very deep into the coronary sinus. And this is position in LAO of the ablation catheter. This is the extraocular pathway where we could actually map and successfully ablate. So as you said correctly, there is a line of block from the previous ablation. So the activation on the left atrium goes laterally and blocks into the area of the previous ablation and goes all around, and that's why, and this is in RAO, that's why you get this pattern of activation of the coronary sinus, which goes really on the line of block, which is on CS34, and all around the other way around, going from the proximal to distal CS. And eventually we chase the ablation is in that position, very short VA, and we use now always irrigated catheters for Wolf Parkinson White ablations, and eventually in 500 milliseconds before very, very early on the VA conduction was abolished, and the patient is well now. So thank you very much for your attention. Yeah.
Just want to credit David Durian.
Yeah, exactly. I know that David showed something similar a few years ago, and that's what we said in the lab when we had the case. David showed us in the past that when you fail the previous ablation of Wolf Parkinson, you have to take in consideration that you change the activation pattern on the mitral annulus, and you can have these lines of blocks. They can fool you. Eventually, you could go and map on the posterior septal area and trying to ablate there and stay there forever and failed again. So it was very interesting to have a similar case as you showed a few years ago. Thank you very much. Yeah.
Yeah. I think that you had a slide that was showing at the beginning where the ablation had been done before.
Well, I don't have.
No, I can tell from the retracing.
Ah, really? From the, which one?
The early one.
I show you this one. Tell me when to stop. During the AVRT?
During the maybe first one before.
This one?
Yes, yes. I think when you were showing this, I was thinking maybe there is something here
Yeah.
that is kind of
Fragmented.
kind of thick, and you are here a double atrial electrogram. The one that represents the wavefront coming from above and the one on below. So I think that you might have been sitting on the prior ablation site here, and this is a good hint again to prove what David has demonstrated before. And I thought maybe ablation was done here before,
Yeah.
and he just correctly went on more distal.
Yeah, yeah. That was the position of the catheter. It's probably a little bit deeper at that point. That's a little bit backward. But as you said correctly, yeah, it's you can appreciate some fragmentation of the between the V and the A in that area, which is the area of block of the previous ablation. Yeah.
No, serious. Actually, so most of the cases, this pattern, when you're going down there, close to the what we call left-sided isthmus between the left anterior pulmonary vein and mitral annulus.
Yeah.
They say it's more easy to damage the conduction along the isthmus than along the mitral valve. Then you can get these patterns, but I'm sure it could be upper and lower, and it's nice. It's so high, never seen. And the challenge is put the ablation CS cutter all the way in, then it makes it.
That's easy. No, that's a joke. Good, thank you very
Just
much.
like in the EP lab, we have reached an endpoint because the pizza arrived. So I want to thank Paolo again for his talk. He has to leave now soon after the pizza. Anybody who has